Okay, I can never tell when these are going exactly live, but we are live, I believe, on Instagram, Facebook, and YouTube, and maybe some others if our fine social media department here at Midwestern University has helped us out. My name is Dr. Mark Kargela. We're going to introduce ourselves in a little bit, but I wanted to welcome you all to our physical therapy live event. Really appreciate you jumping in, and hopefully you'll find some value in what we have to discuss today. If you don't mind, I'd love to hear where you are all viewing this from. So in the comments, whether you're on YouTube, LinkedIn, or Facebook, if you can drop a comment where you're viewing from. We'd love to hear where folks are at. And then we'll give you probably about a minute or so for folks to get in and tune in and let some of the people that are responding to their alerts via social media to join the live stream. And then Tom and I will start. We don't have any brave people making that first comment yet, but I'll wait for it. But let's see. We got 12 people. Like I said, we'll give it about 30 seconds to a minute just to let people join. Great. We'll get started.
Well, I'm coming from the Chicagoland area, Mark, so I'll be the first to say it.
Ninab, good to see you. Thanks for joining us. Yeah, well, the Chicago area is getting nicer from what I understand this time of year.
It's been like 80 degrees the past couple of days.
Yeah, I can get used to that. Phoenix is back down to 80. We were getting close to 100, a little too early for my likings, but I'm sure the folks here in Glendale that are watching can relate to that. But, all right, well, let's get started so we can respect everybody's time. We'll introduce ourselves. My name is Dr. Mark Kargela. I'm a physical therapist, clinical assistant professor here at Midwestern University. I've been with the university for 5 years and been fortunate to get to know a lot of our amazing students and staff and faculty here. My special interest is chronic pain and orthopedics. So looking forward to talking with you guys a little bit about demystifying some of the issues that we commonly deal with in clinic around arthritis. But Tom, why don't you introduce yourself?
Yeah, Tom Dillon, similar sort of title here at their Downers Grove campus, clinical assistant professor in physical therapy. Most of my time's in the clinic treating. Orthopedics is my specialty. A little bit of teaching and a little bit of research in the clinic as well. So I'm excited to kind of just have this casual conversation and talk about some of these common things you and I run into all the time when it comes to arthritis, and hopefully someone out there hears us and finds that little pearl that they can then benefit them, or at least have them go talk to a therapist, or at least have that information for them. So.
Yeah. And as you are watching, I mean, this is for you all who are watching, hopefully get some value, like I said, out of what we say today. So don't hesitate to comment. We're going to try to respond to comments real time as you make them. So any questions that come up or any concerns or anything, definitely put those in the comments and we'll try to respond to those real time. But let's start out a little bit about some of the misconceptions. And one of them is just, well, what is arthritis? So Tom, what are your thoughts? What is arthritis?
Yeah, I mean, I think we can really start off the bat with what will probably turn into one of our misconceptions regarding arthritis. But I mean, in a sort of a quick and dirty way of describing it that I've often find myself doing with patients is you hear about it as a mechanical problem. You hear about it as a problem in which there's wear and tear on the surface of the joint. The cartilage is worn down. There's less joint space. So we start to have, limited mobility and pain associated with that. And that's very true. I mean, that is at the core of kind of what we're dealing when we're talking with knee and hip arthritis, these weight-bearing joints. In addition to these extra stressors, because of the cartilage degeneration, we may be experiencing some bone spur development and some of these structural changes that are, I would say, the majority of what people refer to when they're talking about arthritis. I do think it's pretty important to kind of take a step back, though, and talk about what does arthritis mean with the system of our whole body? And I think anyone listening out there, one of the biggest things I would love them to leave here with is to understand that it is not just a structural problem. A lot of what we're dealing with, I mean, even in the name arthritis, it implies inflammation, and that's exactly what's occurring. But it's not just local to that one spot, unfortunately. If someone's dealing with chronic arthritis, you start to see this inflammation is persistent, and chronic degrees of systemic inflammation can really cascade into all sorts of health issues. And it really can lead to, if you're dealing with pain and you can't quite move and you're having this inflammation persistent in your body, then you start contributing, and I'm not saying there's a causal relationship here, but contributing to things like just generalized weakness, diabetes. There's even some suggestions of dementia and Alzheimer's that are related to this chronic level of inflammation. So it's this awful cycle we find ourselves in where we don't want to move because it hurts, but we're not moving so that we're becoming less mobile. We're still leaving the inflammation in our body. And now we're stuck in this cycle of pain and inflammation and other health issues. I'm not sure, if you have thoughts on that, but I do think it's less just a mechanical problem and is something larger oftentimes.
Yeah, I think it goes to, and we'll talk about imaging here in a bit as far as how helpful that can be in helping us kind of work with this condition. But there's a lot of research coming out now talking about metabolic syndrome and how that contributes to arthritic issues and some of the inflammatory components, not just within the joint, but system-wide within our bodies. And folks that are struggling with obesity, we know excess abdominal fat can really create, pro-inflammatory markers. Adipokines are the fancy words for some of the cranky chemicals that can get released when we have a lot of that on board. There's issues for folks who are struggling with diabetes, cholesterol control, and these things. I always think about, I have like an 89-year-old, he's soon to be 90-year-old patient right now who's got the worst looking x-ray. They graded it the worst you can grade two knees with it. And he was working with myself and some of our great DO physicians in our multi-specialty clinic, and came in to see us in a wheelchair. Literally couldn't walk because his knees were in so much pain. And as the DOs were working with the metabolic health, getting blood sugar, cholesterol, all those things under control, we did some of the movement things that we'll speak to today. And he's now walking, community distances with a walker. He's doing so much better. And a lot of this I would attribute definitely some to the movement and exercise component, but also to getting that metabolic situation under control for him. So I think looking more than the joint, because there's some people who have terrible looking x-rays who have minimal to no pain. And then we have people who have mild changes on x-rays and have like the worst films ever, or have the worst pain ever. So I mean, it's one of those things where we have to kind of put things in context of the person in front of us. And that's maybe segues a little bit into our discussion on imaging and x-rays, because we get a lot of questions about that clinically of like, man, do I need to get imaging before I see you in PT? I mean, shouldn't you know how bad the arthritis is and things? But Tom, in your experience, how helpful is imaging? Obviously it has a place. We're not here to say it doesn't, but where do you feel like imaging and x-rays kind of fit?
I mean, just to clear the air here, physical therapists in most settings, majority of settings, do not produce imaging themselves. I think the closest we come is real-time ultrasound imaging, which in general, I'm a fan of imaging. And I like x-rays and MRIs, and I find the usefulness of all that. I personally use real-time ultrasound imaging in the clinic, and I find that very helpful. However, imaging to me is a component of my exam. And the common theme you'll hear, I'm sure Mark and I talk about is, each person dealing with and struggling with arthritis who's seeking out help deserves to be looked at individually. So if that involves images, if they've received x-rays, then great. That's part of an equation. But I have learned over the past 15 years that I do not put all my eggs in that basket. To me, imaging is a snapshot, a moment in time. It can tell us some good information, but it absolutely should not be the only component of our exam that we use to kind of develop a plan or whatever. I mean, how many times, Mark, do you get a patient coming in with, arthritis as the diagnosis and says, the doc said it's the worst knee they've ever seen, like you said, or it's bone on bone. That's such a common phrase. And I have nothing against that necessarily. I've seen some pretty gnarly x-rays, but the correlation to symptoms is definitely not one-to-one. If we did an x-ray of all of our joints, attending this, listening to this, some of us would have decreased joint space, maybe some bone spurs visible on an x-ray, but we may be asymptomatic. So it's not a direct relationship. And the decision process you make as a patient or as a clinician shouldn't solely be on that image. But I do support imaging. I do want to make that clear. It's a part of the exam.
Yeah, Steve is putting a question out there. Is PT an alternative solution to having hyaluronic injections? I think it's an alternative, but also could be a kind of partner with hyaluronic injections. Now, sometimes some of our physicians who do those injections, there may be some limits, or they might want things to rest or settle in before they re-engage in PT after those injections. That can be the Synviscs, and there's another one that escapes my mind, but that's the most common one that you'll see some of our orthopedic colleagues maybe trialing as they're trying to manage some arthritis. It's definitely not required for folks to engage in physical therapy to have those injections. We see folks that don't have those on board and still do very well in PT with an arthritic diagnosis. Also have seen folks where that's been a part of the treatment plan, and they've felt significant benefit from it, and that's been helping the program along. I would just say that there's not really one often solution to this. I think, as we've alluded to, some of the metabolic health conditions, I think we have to look big picture on how's the whole human and the whole human's health in regards to this arthritic issue, and not just tunnel vision just at the joint, because the research is really pushing us to do so. But thanks for that question there, Steve.
Yeah, if I could just chime in one thing as well. With those injections, my advice for people is I've seen two outcomes for general injections like that it either helps or it doesn't. And it has been incredibly rare that I've ever seen a case where things like dramatically worsened from it. So within the conversations of your doctor, your physical therapist, if that's a right route to take, or if that's something to try, by all means, I think those conversations absolutely could lead you to that. And I sometimes think that those injections can help you tolerate movement better and help you tolerate exercise better. So, in the right hands, the right person, I think they can be to your benefit, or unfortunately, they just might not work.
Yeah, and that's okay. I don't think there's anything wrong. I think it's a safe intervention. Obviously, you want to discuss that with your physician, your orthopedist, who's offering those, to make sure it's a good fit for you. But yeah, it's definitely not anything that I would discourage folks to pursue by any means. If it can bring some benefit, then I'm all for it. Anything that brings people closer to their goals, we're fans of. Getting a little bit back to imaging, just because, and Tom, you alluded to it a bit as far as some of the mindset that folks have about it's bone on bone, and this will go into some of our is exercise safe things. But it really, some of the words and the verbiage around x-rays can really make folks not really want to engage with us in physical therapy, understandably. Like degenerative joint disease, my joke I always put in clinic is that's like calling this scalp degenerative scalp disease, because it's a natural process to some extent, but we've made these horribly sounding scary words that are associated with it, that I don't blame anybody. Without knowing like the research and the science behind arthritis, I wouldn't be very confident that I'm safe to engage with a physical therapist. And then we'll get into that in a little bit more detail here in a second. But I just think we have to be careful with this bone on bone thoughts and the wearing away of cartilage. I've heard the tread wearing away on the tire, which isn't necessarily a bad analogy, as long as you understand that it's still safe. That tire still needs to get on the road, that you still need to be able to play with your grandkids. You still need to be able to get upstairs. Sometimes these words take people away from the very valued activities, and we're seeing that movement really can have a positive benefit of it. And not
right. I mean, imagine that the patient then, and we see this all the time, not just with arthritis, but the patient then feels they're scared to move now. Yeah. I don't want to make my situation worse. If this is a problem with me putting weight through that joint, I'm not going to put weight through that joint. That is absolutely the wrong decision to make, because we know, and as we will continue to talk about, is exercise and movement, weight-bearing exercise, incredibly healthy for the joint, even an arthritic joint, especially an arthritic joint. So, then we're back in that cycle. Oh, I don't want to move. It's going to worsen. So now I'm not going to move, and now it's worse, and I'm stuck in that inflammatory cycle.
Yeah, and that's where I think it like I mentioned, it takes people away from the very treatments that could start moving them out of that cycle with moving and things. And we'll talk about, exercise and some of the approaches to it, because a lot of people might be watching it and say, well, I tried exercise and that failed me miserably and there's some reasons why that may happen. Now, we're not here to say everybody does amazingly wonderful with exercise, but I think if you use some concepts that we'll speak to, you can definitely have some abilities to improve and move forward with it. We talked a little bit about obviously exercise, and we're going to go into more of that, and Tom's going to talk a little bit about some of the other things besides just what we traditionally think about with exercise. But any other common treatments that you find in clinic have been helpful for you, Tom?
Outside of exercise, you said?
Yeah, outside exercise. We're going to get to that here in a second.
Yeah, I mean, in terms of some of the secondary things, we talked about injections a little bit. I can see that, we did speak to that one. It can assist in allowing someone to move a little better, or it may not help. There are passive treatments that I think beyond movement and exercise, and a lot of these other treatments, in my opinion, do help in a sense that they allow the person to eventually then get to move and exercise better. So if you're dealing with, if I have a highly symptomatic, high pain, high irritability sort of knee, and they have restrictions in the knee, soft tissue restrictions, or their joints not moving quite well, especially if they can't get the knee straight all the way, maybe part of my treatment is hands-on manual therapy, where I'm really trying to get the mechanics of that joint just a little more sound, so that when they do stand and exercise, that there's an equal weight bearing on it. It has its full motion available. So, things like manual therapy, these can allow that better joint movement. Soft tissue work or massage, that can lower some pain thresholds maybe to get them comfortable moving. But these, I will say out loud as well, a lot of these treatment techniques alone are inappropriate. If you just did that and said your knee will be great, see me 3 days a week just for this stuff, unfortunately, is not going to get you where you need to go. It's allowing us to then proceed into movement and function and things like that. I also, you might have any PTs out there that may smile at this one, but I have used athletic tape several times. If someone has high acute pain and I just want them to get out of that chair and move a little bit, and slapping a piece of tape in a particular direction helps with that on their knee or hip or wherever, then so be it. It's one of those interventions that the risk is nothing. It is the risk of wearing a Band-Aid. So if that gets you to move more, then I'm going to try it.
Yeah, no, I think, there's a myriad of things we can do, and you mentioned the passive part of it, which again, nothing wrong with that. I utilize manual therapy quite regularly, joint mobilization, manipulation of knees, hips, and different things. And they can really decrease sensitivity of a joint, improve mobility of a joint, and help people on the journey. But the one thing I will tell patients is your life is not lived laying on a treatment table. Your life is lived moving. And that's where, as Tom alluded to, we need to get folks off the treatment tables, get them engaged in things that start pointing them towards their goals, which is often where we encounter some of the challenges with fearful beliefs of like, I don't think I'm safe to do this. The doc said my tread's wearing out on my tire. And again, well-meaning things. I just think sometimes the message gets misconstrued of like things aren't safe to be moved and engaged. But there's quite a few common treatments. You might, Midwestern, we don't have aquatic therapies, but you might hear some folks. I do have a lot of patients who do their at-home aquatic therapy. A lot of folks down here have pools where they're getting in their swimming pools and using that as an adjunct. Again, some of the similar concerns is, again, I wouldn't even say concerns, but like eventually we got to get you loading your body on land to where getting up a stair step with your grandkids, kneeling down, doing things that you don't do in the water. Water can be a nice bridge to that activity, but you oftentimes have to start moving a little bit. Steve had recommended or had asked a question as well. Once starting PT, how many treatment sessions per week would you recommend? That's kind of a variable thing depending on the patient and how acute things are. Sometimes early on, if they're really having struggles, pain's really a big issue, and we can offer them some things more frequently. Oftentimes, myself, I'll see folks maybe at most twice a week, to where we're doing some things to quiet things down, get things to where they're moving and different things, and then moving towards less frequent PT visits and really having people moving to engaging in the things in life. Because again, I tell people, like, I'm happy if you move well in the clinic, but I'm more happy if you move well in the context of your life, where that's where your grandkids lie or your golf lies or whatever it is important to that person that's missing. So we try to start bridging these in-clinic appointments to out-of-clinic things they're doing with the PT's voice probably in their head of how to engage this stuff, how to successfully get back in these activities, teaching them, guiding them on like progressions back into golf or progressions back into hiking or whatever it might be for that person. So any other thoughts you have on that one, Tom?
Yeah, I mean, I'll give my little spiel on PT frequency in general. I mean, like you said, it's incredibly variable, but think of a situation where you've never really exercised before, you have a fair amount of symptoms. You may do better with more PT sessions, more guided sessions. The other idea is that we hold people accountable. They have an appointment. They need to come to their appointment. That's just how society works, right? And so You have struggled with doing things on your own. You just can't get the motivation, can't find the time. But if you schedule an appointment, you're going to do them. Well, then great. Maybe you need more. You're a weekend warrior. You know how things work. You know how to exercise. Well, maybe you just need a guided program. You follow up every couple of weeks just to make sure you're doing well, or maybe you just need a single visit, a couple visits. So like you said, it varies quite a bit based on what the patient needs and what's going to give them the best outcomes. I see people 1 to 2 times a week. And like you, I taper away as they get better, as they get more independent with what they're doing.
Yeah, no, I like what you said there as far as really tailoring it to that person. Some folks are very much want the guidance, want the more, hands-on approach, which is fine. And then some folks are more independent, can like, hey, just give me the tools, give me the guidance, and I can do some of this on my own. So there's some flexibility to fit to the person in front of us. So there's no hard and fast rules of you have to do the specific frequency or not.
I think the content of the session, and speaking of arthritis directly, I mean, we're highlighting a few things here that I think if you're someone out there that's thinking about PT or is in PT and reflecting on your own physical therapy, we've talked about these passive modalities and these passive treatments, but we keep bringing up loading the body and putting it in a challenge position. What are your thoughts then if we're challenging someone and it hurts? I mean, is that pain the automatic kill switch, pull the parachute, get out of there? How do you describe to a patient, well, yeah, I go to PT and it hurts. What do you want to know about that situation that helps answer that question?
Yeah, no, I think that's a good point, because a lot of times people have come through and they've exercised, or they're saying, I'm trying some things away from PT or before I came to see you, and just exercise isn't happening for me. And, the joint, having a good understanding, okay, arthritis structure definitely can be part of it, but that structure is safe to load. And in fact, the data around exercise show that it helps kind of reduce inflammatory markers within the joint. It helps decrease some of the it's like a natural anti-inflammatory. The problem is the dosage that a lot of folks have. And it's either that they go in these like boom bust cycles of like, they're either completely avoiding the knee, or the hip or the shoulder, whatever it may be for that person, where they really have adapted, we call it avoidant behaviors, where they're just avoiding loading, which again, a lot of normal behaviors when you're having a painful something is to avoid it. But the joke I say here in Phoenix and thing is like, you're never going to get your skin tolerant to the sun if you live in a cave. You have to eventually engage and load that joint. The crucial thing that we help people with is like the how much and how frequently and how often. And there isn't a recipe that you can go look on Google where it fits everybody, because we have to know that unique person's metabolic health. We have to know that unique person's movement history, is how much they've moved in the past and where we can start, but also not making everything so pain contingent. Because again, it is okay to nudge into some soreness and sensitivity. The interesting thing we'll see with people is, because some people are like, I don't touch that, don't go near that. And then we'll put people in clinical situations where we find that nice little nudging dose that they're surprised that the more they move, the better it feels. And some of you watching this might even have that experience where, God, the more I walk, the more I move, that joint loosens up. Your body's telling you movement's helpful. You just might need to, as far as if you're struggling with exercise, to like get the help of somebody professionally to get you on a really program that's tailored to yourself, to fit that, how much and how intense that movement is to yourself. So some things I use clinically, and I'd be curious to see what you do, Tom, but kind of general rules is like, no more than a 4 out of 10. You could say up to a 5 out of 10 for some is kind of an acceptable soreness, but it should be temporary. And within 24 to 48 hours tops, it should be kind of abated and down the baseline. The interesting thing we'll often see clinically is that the more they engage into that nudge, that the exercises that at the beginning we're starting to produce soreness and sensitivity no longer are, because your body's doing what the human body's designed to do. It adapts, it gets used to it. I always say we're trying to build the callus, not get a blister, to where you're just loading the body to where it gets tolerant to load. You do it enough, and your body is by design of how it works is it adapts to load, provided you structure that load at an appropriate dosage for your unique situation. What are your thoughts on that?
Yeah, definitely. I do the same spiel of my go-to number has been 3 to 5 out of 10, but it doesn't really matter. The big phrase I tell people is tolerable. And does it resolve within that 24-ish type of hours? And like you said, with repetition, I mean, there's a whole pain neuroscience here that we're not even going to touch on that involves in changing the sensitivity to these stimulus. And that consistency and repetition is in hitting that threshold a little bit with loading during exercise is where we achieve a lot of that. So, yeah, I think pain's such an umbrella term. So when you have pain, that's when you work with your therapist and say, well, then they're going to say, well, describe it for me. How long does it last? Blah, blah. And then they will be able to identify whether or not, we're in a dangerous situation. But oftentimes, how many times do you wake up, oh, my elbow's sore this morning. I wonder why. Oh, weird. And then it goes away. Sometimes pain exists, a low tolerable level.
Yeah. I would agree. I think, there's just a lot of, fearful information about exercise and folks who have the thoughts like, of bones wearing away and different things where, thinking it's not safe and things. But again, the body, like as Tom alluded to, some of the pain, science behind it, as far as if you can decrease the sensitivity of your tissues and the nerves that innervate those tissues through exposure to the stimulus that it's currently sensitive to. Again, it's just working with somebody to help you zero in, well, how aggressive do I go? How far should I go? But that becomes the key too, because I think sometimes where rehab has fallen short in the past is we underdose people with exercise to the point that they're doing all their exercises on laying down on mats, and not that that's bad. That can be definitely part of the gig, but eventually we have to get people to start, stepping up a step or doing even a squat. We teach people squatting mechanics that might help unload knees or hips or do different things that they're surprised that, golly, I can do that. It doesn't nearly hurt as much as it was. And a lot of it is, a little bit of some psychology that we all deal with when we're fearful to load things. The more it's exposure-based treatments where you're exposing yourself to your feared stimulus. And the more you expose yourself, your body loses some of that protective sensitivity to it, and you start adapting to it and doing well. So
and a lot of these individuals with arthritis can be older adults. And that's a failure on us if we don't load them enough, if we don't challenge it enough, because we're afraid, it might hurt or whatever. That's a huge point. That's a physical therapy issue across the board is are we appropriately dosing and loading people? So I like that.
Definitely agree. And I think just to finish up this exercise topic, because there's this belief like if you run or you're on your feet a lot, you're going to wear out your knees. And there's been studies to show that it's a bell curve you're trying to find of being active and engaging. Now your joints are, if they're sitting still, they're not moving. I've heard some physicians call it the disease of rest and rust, where people aren't moving. Those joints thrive on movement for joint health, and some of the tissues in there thrive on movement to kind of percolate some of the joint fluid and different things. We're not going to get into too nerdy of the mechanics. But there's the studies that have shown like recreational runners who are hitting like a middle reasonable distance of running on a regular basis. There used to be a stuff, well, their knees are going to probably wear out more quickly than folks that don't run. Well, lo and behold, studies have shown that people that are running, now I'm not saying ultra marathoners who are probably exceeding body tolerance beyond what, a recreational runner is, but folks that are staying active and running and stuff, that often can help keep their knee healthy and engaged. I think sometimes people get pulled away from these activities out of fear, and often re-engaging them. They might need to step back, and we might need to help build them back up to where they're tolerating that again. But that can be something that is safe to re-engage in. And I think there's no hard and fast rules that any of these things are dangerous. I think for the vast majority of things you're safe to engage.
I agree.
The other question that we often get asked clinically, we're not, Tom nor I are going to claim to be a surgeon, but I think we're well versed on the literature around the topic of surgery and what we see clinically. Obviously, we have the great, privilege of working with a lot of people who are dealing with various arthritic issues who are considering surgery. Where do you feel the role of surgery is, and what have you seen in your practice, Tom?
I will say that, one of the most common post-op care patients we see is a joint replacement, knees or hips, especially, mostly knees. Hips, or some may argue with some improved approaches to hip replacements requiring less therapy. I could probably give my spiel on that a bit, but surgery, I'm a big believer of first step conservative care. And I think, as I want to repeat myself, is that is often a combination of things. It is not only exercise. It's not only, massage. It's not only oral medication or a steroid injection or a knee brace, which again, if it works for you, great. I've given those out before, just a general knee brace. But it is a combination of these things, individually tailored to that person and what works for them. Now, when conservative treatment fails is often where that question starts to become more of directed at me is, well, should I do surgery? I think surgery is a great intervention for arthritis for the person who has reached that limit. And that limit is not decided by an x-ray alone. It's not decided. I think that decision really, if we think about it, comes from the patient. If they've tried these other things and they wake up one day and they say, I cannot do, my quality of life has dropped. I mean, that's the big one, quality of life. I cannot do the things I want to do. I cannot do the things that make me happy. And I've tried this other stuff, and now it's affecting me largely. Then it is a fantastic solution. It's such a common surgery. Now, there's not complications. I mean, you can't expect not, you're going to have rehab. You're going to have a recovery period. There's going to be post-op pain, post-op swelling, restrictions, a learning curve on how to operate this new thing. But I am pro-surgery when it's needed. I just think that it has to come from the patient, and it's largely dealing with their quality of life.
Yeah, I would agree. I think, obviously we're biased as we provide conservative care, but the research would definitely support that thought process.
And insurance.
And insurance companies often are going to require that. But, and again, it's not just because, some folks get, a little bit ruffled when we talk to the insurance company. We're going to focus on what's best for the patient, and what the research and the evidence shows and what we see clinically is that conservative care is a great start. And Tom and I are going to be in here saying everybody succeeds beautifully in PT. There are definitely patients where Tom and I both recommended, hey, we've tried it. This appears to be beyond, where conservative care is helping. You've done injections, you've tried PT, you've done all the things. Now it's maybe time to really, work with the orthopedist. The gentleman I alluded to earlier, who's 89, he just medically isn't stable enough to go under anesthesia. So surgery isn't an option for him. So, but lo and behold, again, his worst x-ray that the radiologist, he's graded as high as they go and has minimal to no knee pain most days. He still gets it when he loads and does some things, but he's walking significant distance. He's loading his knees and different things. When we talk about surgery, there's this belief too that it's going to be a curative for everybody. It's great and it can definitely help people, but there are 20%, if not sometimes higher, folks that still are dealing with pain post-operatively after a joint replacement, because there's just a lot more going into a person's pain than just strictly what that x-ray and MRI shows. So surgery can definitely have a role. I would agree it's not something that should be a frontline approach, and that's why you'll see a lot of physicians say, hey, you need to trial this first. And some people come in struggling with that thought process, that why am I here? Like the joint's been told it's bone on bone, and you guys aren't going to help me. So we spend time obviously educating patients on what we've been talking about today. And I always tell folks, if they're very convinced, like this is a waste of my time, I'm just going to check the box before I go get my surgery. It's like, I completely get that thought process. And often people come into us with some pretty miserable experiences of what they've been dealing with. So understandably, I can get the frustration, but I just open a window for them to give it an honest opportunity, honest try, and attempt to let their body, not Mark, who's obviously got his biases on conservative care, Tom, but let's put you in a situation where you give your knee or your shoulder or whatever a chance to succeed in conservative care. I am okay to say conservative care has failed, or I don't even like that terminology, but hasn't worked or hasn't helped. And then surgery is the thing, but there's definitely just such an opportunity for conservative care for a lot of folks. I think.
I like that. If you as an individual can confidently say, I tried, I gave it what I could, and it didn't work, then pursuing these other options is where I would direct them. But yeah, I agree. But on the other hand too, how many times have we had patients, as you alluded to, where the surgery is scheduled and they go through their prehab or whatever, and they start asking you, it's like, do I need to do this? And so, I'm not saying that they're cured and they never have to get it eventually, but that can happen as well. And it's a wonderful thing. And maybe they delay, a traumatic surgery then down the road for a few years or whatever it may be. So yeah, all sorts of situations.
Definitely not an uncommon thing where people are like set up, scheduled for surgery, and they're doing some prehabilitation, and they see that, gosh, if I load it, it feels better. I start exercising, like you guys say. You guys help me find out the dose that's working for me, and I'm doing pretty dang well. And my quality of life ain't too limited right now. And then again, maybe they do end up getting surgery further down the road. Maybe they don't. Who knows? But I do think there's definitely the window for improvement that sometimes I think we should at least give our joints an opportunity. Nothing wrong with surgery, but I think most of us would agree if we can avoid having invasive surgery, it's not a bad thing. But we have some amazing orthopedic colleagues who do a great job when you need it. And I think they prefer to have it down that pathway too, when they're operating on people who have tried the right things before they hit the orthopedic office. But Steve had asked a question, Tom, who runs the PT sessions at the clinic? Students, doctors, who's overseeing things?
So in every clinic's a little different. Physical therapy as a profession, I would say at this point, many, not all, of course, but in the past 2 decades, it's been towards this doctorate level degree. So oftentimes in a PT clinic, it will be the physical therapists that are kind of leading the show there. In our clinic here, we have different specialists that have our own population. We really have an interest working with, whether it's the inner ear vestibular, whether it's a lumbar or low back or cervical spine or whole spine issue, facial pain. We have someone that works with that, orthopedics like myself, pelvic floor, women's health, these sort of different specialties. And then our clinic is a university-based clinic. We have students with us. So for being trained under us, all my patients see myself and the student if we have students at the time, but I'm always present. So I don't know if that answers it directly, but that's kind of how our clinic operates.
In our Glendale clinic, it's similar. We have students who kind of come in on our Tuesdays and Thursday mornings, and they will help us, and we will oversee them, kind of helping us execute evaluations and treatment things. We're in the process, I think, starting in August, we'll have some full-time rotations where we'll have students who will be overseeing and supervising them as they're gaining their training as to become a doctor of physical therapy. So in those cases, they may manage independently a caseload with myself, or in our clinic, Dr. Klausing, I think, will be supervising the students. The supervising PT will always be making sure that everything's going as well as it should be expected. And the students, we're privileged to have some great students at Midwestern who we have full faith in. And when we give them that caseload and have the ability, that is a sign that we have full faith and confidence that they are a good practitioner who's going to give some quality care to the individuals that they're seeing. So thanks for that question, Steve. So we talked about surgery. Anything else? I want to open it up to questions from the audience. I know, Steve, you've been posting some great questions. I didn't know if anybody else out there had any questions about their experience, or maybe Tom, if you have any other parting things you wanted to speak to folks about before we finish up the live stream for today.
This is a grand topic, right? This is something that's impossible to do in 30 minutes, in a live event, but I think it piques questions. Maybe it gives you that little pearl advice. We keep mentioning these common things of how movement is good and not moving is bad. I mean, essentially that's a secret of our job, pretty much. But hopefully, people can have these little elements from this talk. I don't know if we certainly are going to be available, as you'll see our contact information, to ask any questions, follow-up questions. I will say that there is a wonderful physical therapy written article that came out, I believe, in 2018 that kind of outlines arthritis and sort of different treatments and what's effective and so on and so forth. And it's at the Journal of Orthopedic Physical Therapy. And so if you're ever interested and you just want more information and more specific medical information regarding some of the things we talked about, I know Mark and I wouldn't hesitate to pass that along if interested.
Yeah, I would echo that. If you're having any questions or concerns, you can definitely reach out to us via email, as you see up here posted. Also, you're welcome to call our clinics. A lot of patients are like, I'm not sure if this is right for me. I'm going to schedule an evaluation and determine if this might be a good fit. So we can definitely evaluate you and give our honest professional opinion of what we think, and if it's something we think we can help. So we're happy to have any contacts from you folks. I think this is an area of passion as far as getting folks to where we can start looking a little bit big picture on some of these conditions. It's one of these, hopefully we broke down some of the myths that surround arthritis, and maybe considering a more active approach that helps that quality of life stay up there for those of you who are watching. With no questions being posted, I don't see any comments out there. I think we'll wrap up the stream. Anything else for you, Tom, before we finish today?
No, this has been great. Thanks, Mark. Thanks for leading this. And then, we're open to answering any questions. So if you need anything, let us know.
Yeah, thanks for all your time today. We appreciate you spending some of your day with us, and hopefully you got some value out of what we spoke to today. As we said, don't hesitate to reach out to us via the contact information on the screen, and we hope you have a great rest of your day.
Thanks, everyone.